So I'm guessing, I know we do need to stay focused on our time here. So I guess we probably should just go ahead and get started so we can stay on track as much as we can.
All right. So good morning and welcome to the Arkansas Psychological Association's Fall Conference 2020. This year, the Professional Development Committee has once again assembled timely, relevant topics that reflect the current social and racial climate that then influence psychological practice. Additionally, an overview of mindfulness and compassion-based interventions, plus the workshop on 21st century couples therapy, promise to satisfy any clinician's need practicing in the COVID-19 pandemic, which is filled with significant anxiety, depression, and relationship difficulties. Thank you, attendees, for spending yet one more Zoom meeting webinar with us. And to all the speakers and panelists, you are appreciated. Now, Dr. Holmes will go over some housekeeping and other necessary processes for this virtual webinar to be successful. Again, thank you for your presence.
Yes. Thank you so much, Dr. Mays. We appreciate you welcoming our attendees as president of our association. Hello, everyone. My name is Dr. Holmes, and I am the past president of the Arkansas Psychological Association and current chair of the Professional Development Committee. So thank you so much. As Dr. Mays said, we know that there are a lot of webinars and everything going on now. Everybody's on Zoom all the time. So thank you for joining and supporting the Arkansas Psychological Association in our fall conference, trying to do this virtually and still trying to somehow connect with one another as an association. What I want to do, as Dr. Mays said, is just do some housekeeping. So as we get started, if we could be sure in the chat when we get started to sign in to indicate that you are there. So that's how we're kind of going to do our signing in and signing out for today and tomorrow is in the chat function. So you know we have a chat function in Zoom and you have a Q&A box. So we'll use the chat function to sign in, to say you're here, you're present. I see people are signing in. Wonderful. Signing in. People are putting their names. Wonderful. That's where you sign in. We're going to save that. That'll be our way to know that people have been here and been present. So you're going to sign in the beginning and then sign out at the end of each presentation. We'll also try to do verbal reminders so people remember to do that. And again, that lets us know who's here and how we can distribute the continuing education certificates at the end of the conference. So thank you for doing that. And then the Q&A box will be used for our Q&A throughout the conference. So please do that. If you have any questions for the panel, when we have the panel this afternoon, and any questions and for the discussion portion for Dr. Kelly's presentation at the end, please submit your questions through the Q&A box. And that's how we'll handle that. So that will really help us with moving throughout the logistics of today. And I believe there's a way in the Q&A box to make your question or comment anonymous. So just pay attention to that you can make that you can make that anonymous if you need to. So before we get started, I do want to make sure everybody is able to see. Okay, people are saying they can see the title page. Wonderful. That's exactly what you're supposed to see right now. So if you see the title page, Achieving Health Equity, Psychology's Role, that is exactly what you're supposed to be seeing, because that's what we're going to be presented on today. So we just already have it up. So if you're not able to actually see us, that's okay. I hope you can hear us, but the main thing is to be able to see Dr. Kelly's slide. So let me go ahead and jump in and introduce Dr. Kelly. We're so happy to have her here today. She is a licensed psychologist and board certified in clinical health psychology. She has been the director of the Atlanta Center for Behavioral Medicine in Atlanta, Georgia since 1994. And she has been elected the 2021 president of the American Psychological Association. So it is just a pleasure to have her here to present with us and talk to us today about her initiative for 2021 and what she's been thinking and want to present to us about today. In addition to her independent practice in Atlanta, Dr. Kelly is actively involved in numerous professional organizations, of course. So in addition to APA, she's most recently served as co-chair of the Advocacy Coordinating Committee of the American Psychological Association Services Incorporated, and just a range of committees she's been involved in at the national level. She's been a past president of the Georgia Psychological Association and served as the federal advocacy coordinator of the association for 21 years, and has been the treasurer of the Georgia Psychological Association Political Action Committee. So she's been actively involved. And I just want to say on a personal note, when I've gone to the Practice Leadership Conference in DC, I was able to be involved in the diversity track that they have there and just multiple initiatives that APA has done. And it was a pleasure to meet Dr. Kelly through that initiative a few years back. And it is just warms my heart to kind of have her here virtually, remotely here in Arkansas. So I'm just going to stop right there and I'm going to turn it over to Dr. Kelly. Dr. Kelly, thank you so much. I know you have a busy schedule, so we thank you so much for carving out some time here today to be with us in our association. Thank you.
Well, yeah, thank you and good morning. Can you hear me okay?
Yes, we can.
Okay, it's such a pleasure to be here. We've been planning this for months now, and so it's good to see that it is becoming realized. So what I will be talking with over the next couple of hours will be health equity. And I want to spend some time talking about psychology's role in health equity. Let's see. All right, so these are the objectives that I have for today. And one is we want to be able to describe at least 3 examples of how the current healthcare practices that we have now contribute to health inequities. And we're going to identify some examples, at least 3, on how environmental and social factors systematically contribute to health inequalities. And we're going to be able to articulate at least 2 ways in which psychological science and practice can help address these inequities. So how did we get to this point? So where I'm spending all my time with this. So health equity is really going to be, is my presidential initiative for next year. So what happened was I'm a board certified clinical health psychologist. And so I deal with health inequity in my practice. Before that, I did community psychology work and dealt with health inequity there as well. Well, back in February, I went and talked to Brian Smedley, who's the chief of public interest about health equity. And he was just delighted that this is something that I was interested in doing. And he started giving me some reading materials and looking at it from a big standpoint. So we got health equities where it relates to, I do pain management, we have it in SMI, and it's just all over the place. So in February, I talked with him about it, and that was going to be my initiative. And guess what happens the next month? We had this thing and still have this thing called COVID. And it's just like health disparities, health inequities, just like stares us right in the face. And so everything just came together right at that time. So I am in the process of seating a task force on health equity, and we're really getting the top people in the field from all areas, whether it's related to science, policy, practice, education, and training. And so that should be completed hopefully by the end of next week. And we're going to have the kickoff in January. When January comes, we're going to be really up and moving. But I've been doing a real deep dive in health disparities and health equity. And so let me tell you a little bit about the task force. So we're going to have about 13 members with expertise in the relevant areas, looking at health disparities in different BIPOC populations, the effects of built and social environment on health, the psychological research on racism, public policy and advocacy. And most of the task force will be psychologists. We're going to have at least 1 public member. We have already appointed 1 public member. So based on the review of the relevant research, community-based initiatives, and public policy work, the charge of the task force will be to produce a comprehensive report articulated a vision for the role of psychology in advancing health equity. And one of the good things that APA does is that we always, write papers and things, but I want to take it to the next level. So we're not just going to make suggestions and recommendations, but I want us to follow through on things. One of the things that I found in all my research is that when we start looking at health disparities or health equity, most of it comes from public health. It's like, but psychology has a big role here, and that's what I want to see happen, is for us to look at psychology's role in advancing and in achieving actually health equity. So we're going to spend some time talking about health disparities and health equity. And one of the things that I always have to keep in mind is that health is more than just about healthcare. So when you think about that, it's like we tend to think about healthcare, but it's really more than that. So let's look at the definition of health disparities. And this is from the CDC. And they define health disparities as the preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that's experienced by socially disadvantaged people. And this is what you look at. So they have greater obstacles. The socially disadvantaged people have greater obstacles of health based on whether it's racial or ethnic group, religion, socioeconomic status, gender, age, the mental health status, as I talked about, the SMI, cognitive, sensory, or physical disability, sexual orientation, gender identity, geographic location, and other characteristics that's historically linked to discrimination or exclusion. And it's really interesting because one of the things that I've been looking for with my task force is to try to get people with expertise in all these different areas. So when you start thinking about health disparities, you have to think about the social determinants of health. And the social determinants are the conditions in which people are born, how they grow, live, work, and age. And you see all of these factors impact on one's health and the health outcomes. Your economic stability, whether you're employed, can you afford the medicines, the medical bills, your expenses, where you live, and I'll show you some information on that as well. Do we have walking neighborhoods, your zip code, your geography, your education level, how far do you go in school, hunger, access to healthy options. So food is a social determinant of health. And then you want to look at the community in which you live, and what kind of environment that is, and the social support that you can have in that, and the social integration, and of course the healthcare system. Do you have health coverage or providers around you? We're going to look at that as well, and the quality of care that you receive. And so all of those things impact on mortality, morbidity, life expectancy, and other areas, including functional limitations. Now, this is a very interesting slide, because when you first look at this, you're like, man, 51% of the things that we do that impact on our health is related to lifestyle, whether, you smoke or nutrition, alcohol use, or drug abuse. But then you start looking at the left side of that, and guess what? Some of the things that you see on the left side can impact on the lifestyle. So for example, your environment, that impacts on your nutrition, your stress that you have. Okay, if you don't have the adequate nutrition, you're going to be more prone to obesity. So you can look at it in a very simplistic term and say, well, lifestyle, we got to do things to change our lifestyle, but there are things that impact on our lifestyle, and all of those things affect the health status. So a health disparity refers to a higher burden of illness, injury, or disability, or mortality experienced by one group relative to another. Now, a health care disparity typically refers to differences between groups in health insurance coverage, access to and use of care, as well as the quality of care. So what I want to do is spend some time talking about the evidence. This is showing you how health disparities really do exist because we have the evidence. We can say, oh yeah, it exists, but I have the evidence here. So let's look at it in terms of health coverage. The number uninsured, and this is from 2017. So 16% of Latinx uninsured, about 15% of Indigenous Americans uninsured, 10.5% of African Americans compared to 6% of the non-Hispanic whites. In terms of chronic health conditions, look at who's reporting fair or poor health. 17.4% of Indigenous Americans, about 14% of African Americans, 10% of Latinx, and 8% of non-Hispanic whites. So you do a comparison of the non-Hispanic whites and the American Indians. There's such a significant difference between the two. But 42% of African American adults suffer from high blood pressure compared to about 29% of white adults. 80% of African American women are overweight or obese compared to 65% of white women. And we have 21.5% of Hispanic adults have diabetes compared with 13% of white adults. And Asian Americans are 40% more likely to be diagnosed with diabetes than white Americans. And I did not know this, and they're also 80% more likely to be diagnosed with end-stage renal disease. Now, African Americans have the highest mortality rate from all cancers combined compared with any other racial or ethnic group. And there are 11 infant deaths per 1,000 live births among Black Americans. This is almost twice the national average of 5.8 infant deaths per 1,000 live births. Now let's talk about what's going on in Indigenous American. So the American Indian or the Alaska Native people have long experienced the lower health status when compared to other Americans. They have lower life expectancy and the disproportionate disease burden. And they believe that this is related to inadequate education, disproportionate poverty, and discrimination in the delivery of health services. And American Indians and Alaska Natives born today have a life expectancy that is 5.5 years less than the US in all races, 5.5 years less than the US all races population, which is 73 years to 78.5 years respectively. So we can see the health disparity in this population. Now, the American Indians and Alaska Natives continue to die at higher rates than other Americans in many categories, including chronic liver disease and cirrhosis, diabetes, unintentional injuries, assault, homicide, intentional self-harm or suicide, and chronic lower respiratory diseases. The suicide rate is 3 to 6 times higher among American Indians and Alaska Natives than their non-native peers. And this represents one of the greatest health disparities that we see with the American Indian and the Alaska Natives. So they know that this information is there. So now you have the tribal leaders, policymakers, and they're looking at the factors that impact on the health in the American Indian, Indigenous American, including the adequacy of funding of the Indian healthcare delivery system. So what I want to do is pull some data from Arkansas. So I went and looked at what's going on in Arkansas. What are some of the strengths that you have, challenges, and some of the highlights. So the strengths, good news, you have a high percentage of high school graduation, low prevalence of excessive drinking. That's really good news. And this is from 2019, by the way, and there's a small difference in the health status by high school education. Now you still have challenges, and these are like the top 3 challenges that were noted. And you have a high prevalence of obesity, a high percentage of children in poverty, and a high prevalence of frequent physical distress. So what are some of the highlights? In the past 3 years, the drug deaths increased 70% from 12.1 to 14.2 deaths per 100,000 population. In the past 6 years, a high school graduation increased by 9%. In the past year, frequent mental distress, I don't know how they call mental distress, but it did decrease by 8%. And in the past 7 years, diabetes increased 24%. And in the past 2 years, mental health providers increased 9%. That's good. From 213.3 to 231.6 per 100 population. So let's talk about mental health. So 11.4 per 100,000 African American men and 2.8 per 100,000 of African American women died by suicide. And the number of suicide attempts by adolescent Hispanic females was 40% higher than that of the white females. And we find that suicide was a leading cause of death for the Asian Americans aged 15 to 24. And suicide was the second leading cause of death among American Indian and Alaska Natives ages 10 to 34. All right, so we talked about like health disparities, social determinants of health, like where do you live? So look at this. So race, place, and health, and it matters where you live. So this graph here, so you're gonna look at you see the Black residents and the white residents. And so the Black children in counties with high segregation, so that's indicated by the light blue columns, they experience worse poverty, infant mortality, and high school graduation rates than those in the less segregated counties, which are the dark blue columns. And so you can see the impact of the segregation on the Black residents versus the white residents. So the Black residents of metropolitan counties face gaps in health and opportunity, and they are more affected by levels of segregation than are the white residents. So where you live matters. So residential segregation, it worsens the health for the Black Americans, and the link between race, where you live, and health is in large part the result of that unequal access to opportunities in the United States. And we know about the history of the policies and practices that gave access to white Americans, but it systematically denied it to the Black Americans. So addressing health inequities caused by residential segregation requires initiatives that are localized and is really equity oriented. Let's go back. Now, here's another evidence. And I don't know if you guys had an opportunity to look at this, but this is something that really just kind of like stared us in the face. And this is the Black American amputation epidemic. And when I saw this, somebody sent this to me, one of my colleagues and friends sent this to me. And I was just amazed by it when I saw that. Was worse than amazement. It was really pretty distressing and sickening. So one of the things that we find is that the rate of amputations in the United States grew by 50% from 2009 to 2015. And this is an article in Politico, and it shows that diabetics undergo 130,000 amputations each year. And most often, these amputations occur with people who have low income and they are in underinsured neighborhoods. And we also know that the Black patients lose limbs at a rate that's triple that of other racial and ethnic groups. Now, what happens is that there's this simple test called it's a test called the angiogram, and it's the most reliable imaging, and it can show where blood flow is blocked. It gives the clearest picture about whether that person needs to have an amputation or how much of it needs to be cut. But guess what? Most hospitals and insurers don't even require that test. So they'll go on and do the surgery without the angiogram. Then so the amputations increase, and it is particularly so among the poor. So it can save on the preventive side because they don't have to do the angiograms. But guess what? The cost on the other side of that is just so much more significant. So, and it lets the chronically sick and the underprivileged feel the extreme consequences of this. And I say it, but the reality is that the general surgeons have a financial incentive to amputate. They don't get paid if they don't amputate, and they recommend saving a limb. So check out this graphic here. So you got two pictures here of a map of the United States, and it explains the amputation epidemic. And so the map on the left shows the America's amputations from vascular disease. That's the left side. And look at that. Look at that concentration on that lower right level. And the right side shows the enslaved population before the Civil War. So one of the questions that you have to ask yourself is, are these amputations a form of racial oppression dating back to slavery? Something to ask and answer. So there's this physician in the Mississippi Delta, Dr. Thackeray, and he found that the vast majority of amputees he treated had never had an angiogram. So he made it a mission to really start pushing the hospitals and the physicians to perform the angiograms before they would do the surgery. And so he began performing these, about 500 of them annually. And the medical center that he worked at showed a decrease in amputations from 2014 to 2017. The major amputations had fallen by 75% from 24 to 6. And to me, it's like, that is something else. Now, the thing about, if you don't want to just do eliminate health disparities or have health equity because it's the right thing to do, we know that it saves money. So what we found is that the elimination of the racial and ethnic health disparities could save the US billions of dollars annually in terms of health care. So there was a study done in 2011 that estimated that the economic cost of health disparities due to race for African Americans, Asian Americans, and Latinx from 2003 to 2006 was a little over $229 billion. And they calculated that if Medicare could save $15.6 billion per year if health disparities were eliminated. Now, the pie in the sky would be health disparities could be eliminated, but if they could be significantly reduced, we know that it can save a significant amount of money. So they conclude that if the prevalence of such diseases in the communities were reduced at the same prevalence as those diseases occur in billions in saved in 9 alone. So even though we have some compelling reasons that it should occur from an ethical and moral standpoint, from financial standpoint, it really pays to eliminate the health disparities. So the other thing I want to talk about is health disparities in terms of chronic pain. This is my area of research, and this is the kind of work that I do. And I've been talking about this, the disparities in chronic pain, SES, race, and gender all matter. So racial and ethnic disparities have been found to exist in terms of pain perception, the assessment and treatment, and in all settings, whether it's in the emergency room, post-op care, or in outpatient settings. And in terms of all types of pain, whether it's acute pain, cancer pain, non-malignant, and experimental pain. And so the research is showing that the sources of pain disparities among racial and ethnic minorities are complex, and it involves the patient, which is the patient and the healthcare provider communication and the attitudes, and the healthcare provider, who's the one that's responsible for the decision-making, and the healthcare system. So example, access to pain medication. Now, this is a study that just changed my thought process about how physicians treat patients with chronic pain as it relates to race. So this was a big study. It was all over the news, and it was at the University of Virginia. And what they did is they sampled 222 white medical students and residents. How do you see the Black patient? And how do you treat the Black patient? Basically, is what they were asking. And what they found was that 50% of the white medical students and residents believe that the Black body is biologically different and in many cases stronger than the white body. Oh, yeah. You think about that for a minute, that the Black body is biologically different and in many cases stronger than the white body. And the participants of that study who endorsed these beliefs rated the Black versus the white patient's pain as lower, and they also made less accurate treatment recommendations. Now, there were participants who did not endorse these beliefs, and those rated the Black versus the white patient's pain as higher, and they showed no bias in treatment recommendations. Now, this was a big study, and it provided the first evidence of racial bias in pain perception that's associated with treatment recommendations. So, bias in pain perception associated with racial bias in pain treatment recommendations. And it really gave the evidence that false beliefs about biological differences between Blacks and whites continue to shape the way the medical profession perceive and treat Black people, and they are associated with racial disparities in pain assessment and treatment recommendations. So it demonstrates that beliefs about the biological differences between Blacks and whites that date back to slavery are associated with the perception that Black people feel less pain than white people, and therefore they get the inadequate treatment because the recommendations are inadequate. So it sheds light on an unexplored source of racial bias in pain assessment and treatment recommendations within a relevant population with medical students and residents in the context where racial disparities are well documented, which is pain management. And we know now that there's a need for improved training, and we need to have a comprehensive pain research agenda to understand and address these health disparities. Now, we also know that health disparities exist between pain and socioeconomic disadvantage. And people with lower SES have been, they consistently have poor health outcomes, including they have increased morbidity, decreased life expectancy, and they have increased risk for pain. And we find it in all kinds of pain sites. And it's not just the United States, but it's universal. And it's been found in both community samples and in medical settings. So what is a possible explanation? They say, well, people with less education tend to have less pain coping strategies. So higher education is associated with better critical thinking skills. And you have better ways of navigating the healthcare systems more effectively. And there's more effective interactions between the healthcare providers. And all of these lead to greater belief in agency over one's own health. And if the patients feel helpless and they feel hopeless and they have a more passive approach to their recovery, then a greater difficulty with pain is a likely outcome. Now, we also found gender differences in terms of the pain experience. And that evidence for it is wide ranging and includes basic science, epidemiology, and clinical research. And what is found is that women generally experience more recurrent pain, more severe pain, and longer lasting pain than men. And women are more likely than men to experience multiple pains simultaneously. And we know that that's associated with more disability. And it's also having multiple pains is also a risk factor for new pain conditions. So also women experience more physical conditions than do men, and the presence of such comorbidities is hypothesized to be a risk factor for pain. So I mentioned to you earlier that in March, everything just hit us in terms of health disparities with COVID. and it's just heightened with the COVID-19 crisis. And this is some of the latest data that we see. And this is the most recent information that what we see when you is age adjusted, the COVID-19 mortality rate for Blacks is 3.7 times as high as that for whites. For Indigenous people is 3.5 times as high. Pacific Islanders, 3.1 times as high, and Latinos is 2.8 times as high, and Asians 1.4 times as high as that of whites. And you can see even more information. So you have 80.4 deaths per 100,000, or 1 in every 2,050 Black Americans died from COVID. And you can just see how the numbers go over time with the different races. And one in 2,800 white Americans has died from it. 35.9 deaths. And look at that compared to the Black Americans, 80.4 deaths, Indigenous Americans, and Pacific Islanders. So why is this taking such a deadly toll on Black Americans? You even see this all over the media now. And we know that bias plays a critical role in health inequities, and it just perpetuates structural inequalities. It could be either explicit or unconscious physician bias, and it can determine, which patient gets the proper testing and the treatment. So also we know that African Americans have higher prevalence of comorbid health conditions, such as diabetes, hypertension, and heart disease. And African Americans and Latinx are less likely to work from home, as we have the good fortune of being able to do. And they're more likely to be able to have to take public transportation, and they have more crowded living spaces, and increases the risk for exposure to the coronavirus. And we're talking about this more, about the minority and low income communities are likely to experience more food insecurity. So then you're going to have a higher incidence of obesity, diabetes, and less able to have the supplies that they need. And there's discriminatory housing policies, segregation, and poor environmental protections have left many African Americans living in substandard and high density housing. And also minorities are more likely to live in healthcare deserts. And the study found that Black Americans were on average 70% more likely to live in a zip code with a shortage of primary care physicians. And African Americans in some major US cities were also more likely to live in an area with no hospital trauma center within 5 miles. So those are pretty significant things. The other thing to note is that the health is not a direct result of people's behaviors or actions, because it's very easy to sit there and blame the individual, but you just can't do that. So although Blacks' individual actions and behaviors play a role in the health, what we do know is that the environment in which Blacks exist and the policies that are put in place shape people's opportunities, and they help determine what choices they have to make. So you can see that those play a major role. All right, so I had to go back to Arkansas again and look at what's happening with coronavirus in Arkansas. For Blacks account for 15% of the population, but 24% of the state's coronavirus cases. Hispanics make up 8% of the state's population, but 18% of the coronavirus or COVID-19 cases. And whites account for 77% of the population, but 63% of the coronavirus cases. Now, in terms of the last thing I want to talk about is relates to the disparities is the telehealth services. We thought that it would be great that we can have access to telehealth services. People can have, there'll be expansion of services, and people can be able to have access to the care that they, but what we'll find, expansion in telehealth really can end up resulting in exacerbating disparities in care. And it leaves behind the underserved communities. So having access to high-speed internet, broadband is essential for telehealth services to be equitable, but only half of the population in the United States they have either very slow internet or none at all. So they don't have access to that. And so one of the things that the doctors have been doing is doing phone sessions with the patients. And one of the things that they found, like at the end of the month, they're not able to even talk with the patient. The phone is off. Well, the phone is off because they run out of minutes. So they cannot afford the same level of service in terms of the phone access as we can. We have unlimited minutes. And some patients have difficulty hearing well enough to use a telephone. And so even with hearing aids, they have that difficulty. And some just have problems with email, texting, and internet usage. They can't see well and have difficulty speaking. So these are the disparities that we're finding that are existing in telehealth services. And we need to keep these in mind when we're working with our patients with our telemedicine or telehealth. Now, one of the people that I admire the most is Martin Luther King, and he said, of all forms of discrimination and inequalities, injustice in health is the most shocking and inhumane. Now let's talk about health equity. So health equity is the attainment of the highest level of health for all people, that everyone could have that. If it really could exist, that would be great. But it requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequities, historical and contemporary injustices, and elimination of health and healthcare disparities. Now, this is a very interesting picture because if you look at that, you see that equality does not mean equity. So look to the left, they all have the same box, but they all can't reach the fruit, which is what they need. But equity, what you're doing is giving people what they need, when they need it, and in the amount that they need it. So equality does not mean equity. Now, health equity and health disparities are intimately related to each other. Health disparities can stem from health inequities, and there are systematic differences in health of groups and communities occupying unequal positions in society that are avoidable and unjust. Now, health equity is the ethical and human rights principle that motivates us to eliminate those health disparities. Disparities in health and in the key determinants of health are the metric for assessing progress towards health equity. So health equity can be viewed as both a process and an outcome. And it's the process of reducing disparities in health and its determinants. And the outcome, the ultimate goal, is the elimination of social disparities in health and its determinants. Now, I'm going to break this down, but these are like strategies for reducing health disparities, and this is from the CDC. So reducing health disparities brings us closer to reducing health equity. The programs below that I'm going to break down you to are examples of how addressing disparities can advance health equity. But I want you to keep this in mind. I want you to look at a couple of things here. One thing is that some people will require certain programs to reduce the disparities. So this person has to have something to stand up on because they're not necessarily equal. And guess what? And people don't pay any attention to it, but there's always a fence. How do you get on the other side of that fence? Now, so these are some of the programs that CDC had implemented. These are examples. So reducing health disparities brings us closer to reaching health equity. And so this is how some health disparities were done to advance health equity. And so this is some of the things that they've done. They had, for example, case management and home visits by community health workers It decreased asthma-related hospitalizations. Personalized counseling reduced HIV risk behavior. So you can just see all of these ongoing efforts. And lay health advisors reduce HIV risk behaviors. So these are the populations, Latinx children, racial and ethnic minority groups, people living with disabilities, men who have sex with men, American Indian, Native American, Alaska Native populations, low-income populations, and Alaska Natives, high-risk communities, Hispanic and Latinx immigrant men. So all these programs impacted on those populations. But the thing that's very interesting about this to me, when I look at this, is that where is psychology here? Again, we're seeing public health, and I say to you, we have to have a role in achieving health equity. Now let's look at these two models. You got on the left side, you got the socio-ecological model, and that looks at society. And then you got on the right side, which is more individuals based, and that's the medical model. So the medical model says that our health is influenced by a combination of our access to healthcare, genetics, and personal choices. Now, what they found is that, and this is the Bay Area Regional Health Inequities Initiative, that the medical model is responsible for less than 30% of our health outcomes. So look at behaviors, smoking, nutrition, physical activities, violence, chronic stress, disease, and then you have death. Now, on the other side of that, we have the socio-ecological model. And it says that the other 70% or more lies within our social, political, and economic environments. These systems and the rules and practices that they enact and promote determine the distribution of resources and opportunities and who has access to them. So look at that on the left-hand side, you got the race, class, gender, immigration status, national origin, sexual orientation, disability, and weak social compact, social vulnerability. But they are drivers of change down here. People power, youth leadership development, enhanced cooperation and policy innovation, leveraging partnerships and changing the narratives. And so you got all of that, and then that impacts on what happens on the right-hand side. So that socio-ecological model, society, 70%. How important is that? So environmental, social, and behavioral factors, all areas that's in our expertise, contribute to health disparities and interact in ways. So what I say is that we have to position ourselves as a force for achieving health equity by finding ways to make concrete improvements in overall health of populations that are affected by disparities. Now, so this is very interesting here. So we have here how behavior plays a major role in maintaining health. 40% of premature deaths in the United States are due to behavior. 40% of premature deaths in the United States are due to behavior. But remember that graph that I gave you in the beginning, that you got all these other factors that impact on behavior. So behavioral health includes healthy and unhealthy behaviors such as activity levels, stress, diet, medication adherence, and more. Now, how much of this is related to environmental types of factors, whether or not you have a walking neighborhood, whether there's environmental stress that's impacting on unhealthy behaviors, your diet, can you afford healthy foods, medication adherence, can you afford the medications? So yes, it's simple to say that the behaviors have a role here, significant role, but we also know that environment plays a role. Mental health, psychological distress, depression and anxiety. We know that these impact on behavior. And when a person is really stressed, you're going to see them smoking more, using drugs more, and alcohol is a way of managing with these stresses. So you just can't all say, oh, this doing all these things. You have to look at the environment in which they reside. So let's spend a little time looking at psychology's role in achieving health equity. So we're talking about science, policy, education, and practice. All of these that's what psychology can bring to the table: science, policy, education, and practice. We're about practice and intervention. We're going to be talking about it both on an individual level as well as the population health level. Now, this is something that's very interesting. So, APA does a really good job in getting task forces, and they make great recommendations, but things don't really oftentimes happen from them. Sometimes they do, not all the time. That happens from them. But in 2017, there was a working group on stress and health disparities. I did not even know that group exists, and that's despite the fact that at that time, I was the liaison to public interest, which is where this came out of. And I was doing a literature search and I just found that. And I say, man, this is really interesting. I didn't know that it existed. But a lot of the things that they recommend as relates to health, stress and health disparities are applicable to what it is that we want to do in terms of our year. Okay, so, and some of these recommendations that you're going to have, most of these recommendations are coming from that report that they have, but nothing came from it. But these are some of the recommendations I think they're just as relevant now. So the recommendations for research, and I want you to start thinking about all of these when we do our discussion, because I want you to give me some recommendations for science, education, policy, and practice as well. We're going to be talking about that. So for recommendations for research, they say, support longitudinal multidisciplinary research programs that are capable of examining the interrelationships among barriers to health operating at the individual, family, the community, and the national levels. Support research to identify the best strategies to reduce prejudice and discrimination and to identify moderators of response to strategies to reduce race-related stress. So they're talking about stress here, but I'm talking about health disparities. Support research to determine the kinds of social and psychological resources that are needed to facilitate the integration of workplaces, neighborhoods, schools, and other institutions. And support new research to develop the complex models and statistical methods to understand the effects of stress on susceptibility and resilience, and expand fellowships in health disparities, and develop modules for curricula in health psychology and health statistics to facilitate the study of the causes and consequences of health disparities. You know, one of the most challenging things that we have found in terms of putting together our task force is to find, and I know it sounds very interesting, I was trying to find white male scientists that's really doing work with health disparities. And I have been asking all my colleagues in the field, can you give me the names of someone? They're doing something kind of similar, but not really. And so it's really interesting because it's like, so this is putting the burden on the people of color to address these health disparities and not just in terms of practice, but in terms of research, science, and in education. And so we're still searching for that. And I hope we're going to be getting close to it, but that just tells you a lot about the field. We do have the white women are really doing work with it, but we're not finding this as much as in the white males. And you can just think about that one for a minute. We can discuss it. All right, so here's psychology's role in achieving health equity as it relates to public awareness. So one of the things that we can do is partner with community-based organizations, schools, and other professional organizations to plan strategic collaborative efforts to disseminate information on psychological implications of health disparities. So we know that we really just can't do this by ourselves, but we want to partner with the community-based organizations. And we want to develop they recommend to develop a media campaign to help the public, policymakers, clinicians, communities, and individuals understand stressors and their impact on health priority populations and health disparities. And so the campaign should explicitly address psychology's role in achieving health equity. And that's what we're trying to get at. What is our role in doing this? And this is very interesting. So one of the things that we talked about as it relates to our task force is that we want to have a summit. So we're conceptualizing a virtual summit on health equity, and we're going to have that in the second quarter of next year. And we're going to have speakers, topics, key questions for discussions, and expected outputs. And what we want to do is really try to partner with more community organizations in helping that to become realized. And so we have to have a big media campaign for this. And that's going to be my big audacious goal for next year. Is that we're going to be out front and center, really looking at psychology's role in achieving health equity. And I hope that that can be our public education campaign for next year. So I'm going to be advocating for that. Policy, what they recommended was to advocate for funding for research on reducing health disparities for racial, ethnic, and low SES populations, and advocate for access to mental health services for individuals and families for all. As it relates to education, the recommendations improve the capacity of psychology training programs to train clinicians to discuss and address the effects of inequality and injustice on individual and community health. So one of the things that we're also trying to do is get people in a task force in my education community, because we want to really improve these psychology training programs to have health disparities, health equity to be integral parts of that program. So the other recommendation is provide graduate and continuing education training to all psychologists and other healthcare providers working with racial and ethnic and low income or low SES populations to ensure that they are highly competent and skilled in best practices for addressing health disparities. And as it relates to practice, the recommendation is to, now this is from that 2017, which I think is totally applicable to what we're doing now, is to integrate multidisciplinary work from the perspectives of organizational psychology, sociology, anthropology, and other disciplines to develop strategies for improving collaboration and problem solving among diverse groups. So, in addressing health behavior practice, in addressing that, they want to address health disparities in vulnerable populations. Treatment approaches aimed at addressing the health behaviors should be integrated in the treatment protocols. So when you think about your treatment, also think about the addressing the health behaviors. Also, race and SES differences exist in health behavior, including behaviors related to diet, physical activities, substance use, risky behaviors, and adherence to health promoting regimens. So when you start making recommendations for these kind of things with your patients, you have to put them in the context of race and SES differences. The other thing is that unhealthy behaviors such as high consumption of fatty foods, the sugars, the physical inactivity are common and outcomes, and related outcomes such as obesity are closely linked to the onset and course of many diseases, including cardiovascular disease and cancer, as well as cognitive decline and aging. So we already know that. But what we also need to know is that there are other factors in addition to just the behaviors that impact on that. So you look at that 70% that they talked about, the socio-ecological model, that impacts on that other 30%, that medical model, which is some of these things, and then you have the outcome from that. And race differences in health behaviors and outcomes are complex, and they highlight the importance of considering the intersections of race, gender, social status, as they affect health outcomes. Now, I want to spend a little time talking about the population health approach. And I'm going to probably finish, I'm looking at the time here, I'll probably finish before 10:30, and we can have a break, and then we can do some discussion, and the discussion can be more extensive. So one of the things that as I started talking with more people about health disparities, health equity, health inequity, is that we have to start looking at a population health approach. You have to start looking at a bigger picture than just one small the group that comes into the office. So let's look at this. So on the left hand side, you have the goal. On the right hand, these are the people. You have the diagnosed people, the at-risk people, and the healthy people. So for the people who are diagnosed, those are the ones that we typically see in our practice, the ones that are quote diagnosed. Those that you want to make sure that you're going to provide effective and efficient clinical care. Well, guess what? That only gets at a very small amount of people. So if we continue to do things the way we're doing and waiting for them to come to our practice, we're going to get to a very small amount. Then you have the people who are high risk. Now you're getting more larger groups of people. So what you want to do with that population is you want to mitigate the risk and have early intervention. So that's the group that you'll see that's at risk. And then you're going to get to the people who are healthy. And what you want to do with them is to really try work very hard to keep people as healthy as possible. All right, so recommendations for a more equitable mental health system. So I'm going to start with working upstream. And I'm trying to find my parable that I'm going to read to you about working upstream. So public health advocates often talk about health in an upstream, downstream fashion. And they want to highlight the importance of health promotion and the influence of social, economic, environmental, and cultural factors for health equity for Latino and all people. So here's the parable. So a man and a woman were fishing on the riverbank when they saw a woman struggling in the current. They rescued her. Soon they saw a man struggling and they rescued him too. And this thing continued all afternoon. Finally, it's like, okay, we're doing something wrong here. The pair got quite exhausted and they decided to go upstream to find out where and why so many people were falling in. What they discovered was a beautiful overlook along the river's edge without any warning signs or any protective barriers. They had no warning signs and no protective barriers. So the couple went to the community leaders to report the number of victims they had rescued and explain the connection to the unprotected overlook. So the community leaders agreed to install a protective guard and post warning signs, and it prevented the problem and that saved resources, energies, and lives. So this parable shifts focus from downstream, which is individual treatment, to upstream, prevention strategies for the entire community. So downstream, you have chronic disease treatment, emergency services, pharmacology, surgery, and dialysis. And midstream, you have what you want to do is modify individual behaviors, physical activity, nutrition, tobacco use, maternal health, high school graduation, and violence control. And now you want to go upstream, which is what we really want to look at. And you want to address the social determinants of health, the conditions in which people are born, grow, live, work, and play. So remember, we talked about that early on. Is one of the first things you want to do is really address the social determinants of health. And so the social determinants of health, again, are economic stability, what the employment status, whether they're working, are they able to pay their expenses? Can they pay for their medical bills and the kind of financial support that they have? Neighborhood and the physical environment, again, that's, you want to look at that. Housing, transportation, safety, parks. Do they have park playgrounds to play in? What's the walking neighborhoods and the zip code? Education, how the level of education that they have. Food, access to healthy foods, community and social contact, which is social integration, support systems, discrimination and stress. And the other one is the healthcare system, which is health coverage, provider availability, and provider linguistic and cultural competency, and the quality of care. So we were talking to someone that we were interviewing she just does an amazing amount of work on health disparities in the Latinx population. And we were interviewing her about the task force on Monday. And she said that one of the things that we really have to do is we got to go out into the communities. We can't just stay in our office and do the one-on-one, that we have to have services in the places where people go. So the other thing you want to do is you want to empower people to be healthy. You want to have health activation. You want to work with the people who are healthy, because there are people who are healthy as well as the ones that are unhealthy. So you don't want to deny them the treatment or not focus on them, but you want to focus on the healthy ones as well, and really try to eliminate some of the risk factors. And we want to broaden the set of interventions that we use. And so, we have to start thinking about things from different to just, okay, I'm going to do cognitive behavioral therapy. Let's broaden what the set of interventions that we use. Go out and let's work within the community and have some community focus. And the other thing we want to do is to enlist others to help build broader mental health literacy. When I say enlist others, that would be not necessarily psychologists, but engage them as well. And we want to focus on health at the community level, as we talked about, and reframe how people view mental health. That is something inside all of us, that we can be focused on having mental health. All right, so in terms of my presentation, the planned presentation, this is what I have right now, but what I want to do is to move and just have more focus on a discussion about this and where we're going to go from here. And I'll turn it over to the organizers.
Hello, thank you so much, Dr. Kelly. That was an amazing amount of information. We're so glad. It's a lot to digest and process. It is, but it's good.
Yeah, it's a lot of information. I said, well, I was like, I don't have an hour and a half of material because it's a lot of stuff. And so, and I think that we can spend the time discussing it and, and how we go about making a difference in addressing health equity.
Right.
In addressing health disparities to achieving health equity.
Yes, wonderful. This is great. That's why I'm so glad. I just want to let the audience know, because a couple of people asked. Somebody said fantastic information. Thank you. So people have asking about the recording. So this is being recorded, and thank you, Dr. Kelly, for allowing us to record and giving us permission to upload to our YouTube channel. So after the conference, all of the information, not just Dr. Kelly's presentation, but the information from the conference will be uploaded to our YouTube channel so people can go back and review later. Because as Dr. Kelly says, a lot of information to process and digest, and then hopefully come up with action steps to do something with, say, what can we do with the information we've learned? So what we'll do, if you're okay with this, Dr. Kelly, is just take a break maybe before we enter our Q&A/discussion section. So just to give a few announcements before we take the break. After the break, we're going to come back, and we do have time. Dr. Kelly wanted to make sure we had time to really have a dialogue, a discussion, Q&A. So we're going to use the Q&A box for that. So just more than just having like 5 or 7 minutes. So we're really going to have, after the break, we'll have until 11 o'clock to really dialogue, discuss, and really dive into some of this information that Dr. Kelly has been presenting. So again, this is being recorded. And when you go in the Q&A box, you can make your question or comment or discussion point or recommendation. You can make that anonymous if you want. So let's go ahead and take, let's say about a 7-minute break. I have on here is 10:13. So if that's okay, let's do a 7-minute break, and then we'll come back at 10:20. And after that point, we'll have a moderated discussion. Dr. Pat Griffin has agreed to moderate the discussion and Q&A portion. So let's go ahead and take a break, and we'll come back at 10:20.
Thank
you. Give us a couple of minutes to transition over. And if you want to start kind of considering your questions or your discussion points, please feel free to do that. Again, we're going to use the Q&A box. As you come back in, you do not have to sign back in. We're going to just do that at the end. So when you come back, just come on back on and just become a part of our Q&A, our moderated Q&A and discussion.
Pat.
Okay, there's
Pat.
Hello.
Hi.
And again, welcome to Arkansas, Jennifer. What a powerful presentation.
Well, thank you.
Before we get into the Q&A, for those of you who don't know, Dr. Kelly, for a number of years, has been instrumental in launching an initiative through APA to increase the presence of ethnic diverse psychologists in leadership at the state level. Many psychologists throughout the country have undergone that training that she initiated, and I know it was over 10 years ago, I would guess.
11 years.
11 years. Arkansas has been the recipient of that diversity training in leadership, and the beneficiaries are present today with this conference. We have 3 African-American psychologists who have served as president of the Arkansas Psychological Association. I was the first in 2014, yes, 2014. 2 years later, Dr. Kyla Holmes, and our current president, Dr. Cameron Mays, is our 3rd African-American president. We underwent that leadership training, and the association was open and receptive, and the rest is history. So on a personal note, Dr. Kelly, Jennifer, thank you.
Please.
Thank you, because your work is evident here in Arkansas. This has been a powerful presentation, very timely to have this presentation from you as you launched your initiative for 2021 on health equity, health disparities. For such a time as this, we need this message in psychology. As the questions are coming in, and I'm sure that there will be many, we're going to open the floor for question and discussion. Last year's conference was somewhat of a prelude for today, pre-COVID-19. Those of you who were with us in 2019 remember the presentation by Dr. Rosie Phillips-Davis on her Deep Poverty Initiative and the experiential work that we did experiencing in small group interaction and discussion, the oppression of poverty and the effect it has on numerous levels in our lives. You also may recall that afternoon, we had Dr. Sherman James. For those of you who are not with us, Dr. Sherman James originally was a clinical psychologist who completed his PhD from Washington University in St. Louis, but decided to go into epidemiology. He coined the term John Henryism, which is a prelude to where we are today. John Henryism, as you may recall, is a strategy for coping with prolonged exposure to stressors. He has done this work internationally, but he has also targeted the African-American community. And based upon the empirical studies that he's conducted over a number of years, he was looking at the effect of systemic racism on the health of African Americans, independently of socioeconomic status. So this is what we are seeing played out in the national landscape now with COVID-19 and also racism. I know a lot of the focus today has been on COVID-19, but I'm referring to, in discussions that I'm having with colleagues and people in the community, the multiple pandemics that we're dealing with now in America. I think we have one question in the chat, and the question is, Dr. Kelly, what changes do you think will have to occur with the current reimbursement model to promote services to keep people healthy, help encourage good mental health practices? How do you foresee psychologists able to earn a living with this model versus our current reimbursement model that focuses on problem-solving, problem-based intervention? Now, there are a lot of questions there. I don't know if you want to take one at a time.
Yeah.
Did you remember all of those?
Yeah, now let me just tell you this. So this is one of the things that we've talked about, because, you know, and it's a tricky thing for psychologists. So to put it into context, I am an independent practitioner. And I make my money, I make my living by, you know, individual psychotherapy. And just the thought of having to do something different, you know, it's like, oh, wow, you know, that could potentially result in, you know, change in my income. So one of the things that we were thinking about conceptualizing in terms of our recommendations and for this task force is to think about like, how will we look at, you know, payment models for this? And, you know, I think the payment models now are pitiful anyway. So it can't help but improve as far as I'm concerned, at least in the state of Georgia, in Atlanta. But so one of the things that we were thinking about doing is, let's think about how do we look at payment models for psychologists to do this community type of work. The other thing that I was thinking about is let's do a toolkit for psychologists. So we're not saying abandon your practice, but how can we integrate some of these things that we know already that, you know, can work within our practice. So we don't want to say abandon individual psychotherapy and move to the population health model, because it's just not reasonable, feasible for practitioners. And frankly, it would make a lot of them upset with us. And I understand I'll probably be upset with it too. So, but we have to start thinking about this now. So one of the good things that I'm going to be having is we're going to be having our advocacy, our chief advocacy officer, who's Catherine McGuire, will be part of this with us, and also Jared Skillings, and Jared, as well as Stephen Gillespie, and they will be with us in terms of looking at how can we work with this together. So it's like we can make some suggestions, but we have to look at all the various aspects of it and how this impacts on practitioners to really address health disparities and achieve health equity. So it's not just going to be a one thing. And so that's going to be part of what the task force will be looking at. We clearly see that it's, you know, the way it exists now does not work. I don't think that the way the insurance structure is now works that well for much of us anyway. So what are some things that we can do? You're muted, Pat.
The second question, can you give some more specific ideas about where to start as individual psychologists? What would you recommend as a first step?
So the question would be is, first of all, the first step is awareness that this exists. And so, you're talking about where you're doing within your practice, because if we go back to that one slide that I'm going to see if I can find that one slide, that's a one step that we can do. So as it relates to practice. So one of the things that we could do is, we know that race and SES differences exist in health behavior, including behaviors related to diet, physical activity, substance abuse, risky behavior, and adherence to health promoting regimens. So look, how can we address that within our populations, and also focus on what some of those unhealthy behaviors are. Now we got to remember, you got to consider all that in the context of the environment, but how can we target those within that context? So, but we know that things are very complex. It's like, so when I work with my patients on the individual level, what I try to do is I look at things within that social context. So for example, my work is, I do chronic pain management. And many of the patients that I work with have limited income. So they have limited income, and and many of them don't, probably about high school graduate level. So when I try to make recommendations for them, I always try to consider in the context of where they live, the financial limitations that they have. So I can't just say go walking, because some of them don't even live in safe neighborhoods. But we could say you can go and walk in a mall, somewhere that could be a safer environment. So it's like, you have to be creative in making some recommendations that can help improve the healthy behaviors. Now, if you're talking about, if we want to look at some of the social determinants of health, so how can you get involved on a community level to really try to make a difference within your community? Now, I don't know if you have this or not in Arkansas, and but I'm in Atlanta, so we have this program called Leadership Atlanta, and I'm involved with that. And so one of the things that we know in the Leadership Atlanta is that what it does is it builds leaders to help make a difference within the Atlanta community. But one of the first things that they do with Leadership Atlanta is talk about, they have a race awareness day, because we know that in order to make a difference within the community, you have to address the issue of race. And the point I'm trying to get at, if you can get into one of those leadership programs within your community, you will learn a lot about how to make a difference within your community.
Thank you for that. Awareness is very important, and also involvement. I thought it was very significant that you shared with us empirical evidence. As other questions are coming in, please post your questions, because I have several, but we want to give equal opportunity to all. By the way, Jennifer, are you going to make your slide presentation available? It would be good if are you at a point that you can release that or not? I know that
I can eventually, but I got a couple of more tweaks that I'm making on it, but I'll be able to release it to you. So when I did the presentation to Idaho, and I'm going to release it to them as well, so you could be able to have access to the slide presentation.
All right, thank you. I think that would be very helpful, especially with the data that you provided, and I was glad that you included current information on the incidence of COVID-19 in Arkansas. Last night I went to the website for the Arkansas Department of Health to get the most recent, but you had already compiled that in your presentation. So thank you for doing that.
I already did that, you guys.
Yes.
But I was actually quite impressed with some of the positive statistics and things that you have going on there within your state. So you're doing some things, right?
Well, Arkansas is still a hot spot, as you probably have been hearing.
Yeah.
One of the segments that you presented was this empirical research on how Blacks are viewed as having a higher tolerance for pain. And this is historic. J. Marion Sims, the father of gynecology, back during the slavery era, would purchase female slaves to perform medical experiments to perfect instruments. And they had a statue of him. He's been in the news recently, which is why I'm bringing it up, because there was a statue of him in some park in New York. And since George Floyd's murder, I think they have taken that statue down. But that's just one example, and that is historic. And those different views of African Americans within the health treatment model have continued.
Well, you know, it was very interesting that some of the things that they said in that study, and then you got to remember that these are young people. And so this is in Virginia, and this is, you're talking University of Virginia, you're talking about medical students and residents. And so Cynthia Ballard at that time, who was the acting CEO of APA, who had been with over the education director and as a health psychologist, gave me that article. I couldn't believe it. But they had things that they felt that we don't feel pain as much, that we have thick skin, that we, you know, that skin is actually thicker. That Black people's skins are actually thicker, that they have thicker blood. And just, it's like, now you guys are the medical professionals and you're thinking about these things, that these stereotype thoughts that you have to date back to slavery, and you still believe that. And that is shaping, not only do you believe that, but it's shaping the way you view the patient and the recommendations that you make as it relates to treatment. That was quite scary to me.
This is historic. And just as an aside, we have a couple of other questions. There is a book that I would recommend, Medical Apartheid by Harriet Washington, who is an African-American medical ethicist who has documented the historical disparities in the medical field on how African Americans have been treated. We are aware of the Tuskegee study and Henrietta Lacks, whose cancer cells were used without her consent. And this is a well-documented work that she has produced. And the name of the book is Medical Apartheid. So we have a couple of other questions. This next question, I'm intrigued with the idea of embedding services in places people go and enlisting others to increase mental health literacy. Does APA have examples of either, apart from working in primary care settings, perhaps offering information in laundromats, libraries, grocery stores, community centers, et cetera?
Well, you know, okay, I'm sorry.
No, I was just going to repeat the question if you needed me to.
No, I think that that's a good point, because, you know, one of the things that we do a really good job with, which I have my own issues with, and, you know, it's good that we do a good job with primary care, but I think that we need to go beyond that, because, you know, like, yeah, primary care. And so I'm going out, I want to go beyond primary care. I'm out into the community, but I like the suggestion they had about how to disseminate the information into the community. So I don't know of an effort that we've had to do that, but that is something that I am going to note as part of a part of the task force.
All right, we have another question. As soon as you finish writing that down, I will.
Go on.
Can the task force provide ideas or recommendations for undergraduate and graduate programs to integrate this awareness in their curricula?
Yes, so that is.
There's a second part, maybe make it connected with accreditation if it's not already.
Well, that's gonna be interesting about making it connected with accreditation, but I mean, we'll see how that works. But that's one of the reasons why we were very careful in selecting members in the education and training community on the task force, because we know that it really starts with the training and the training programs. And so that's gonna be an integral part with it. And so I don't know how we can do this with accreditation, but I know that we can really be able to start having a focus with that within the in the programs, in the training programs. And that, I guess the good news that we have is that we do have such good connections with people in, you know, whether it's the pre-doctoral training programs, the postdocs, and so we can really try to get this thing infused and implemented in that area.
I think our participants are submitting great questions for you and questions to consider as you launch this task force that will have implications not only at the applied level for practitioners, but also in the academic setting.
Mm-hmm.
Your model that you shared with us is very comprehensive, related to education of health disparities, which is important for raising awareness.
Mm-hmm.
And we are good at collecting data. That's one of our strengths as psychologists. And as you mentioned in one of your comments, a lot of times the information is archived and we don't see it after the research study has been posted in terms of the implementation of it. One piece that I would like for you to address is the intersectionality of psychology and advocacy, policymaking, particularly to address systemic racism. A lot of the information we are aware of and it's been raised to our attention now since COVID and since racism. This is an ongoing saga. This is part of the American tapestry. But as psychologists, what do you see as the role in a social justice position and an advocacy position? And is there a platform for that with your task force as we look ahead?
Yeah, this is a lot of information. Okay, so let me see if I can dissect it all. So first of all, we know that racism and systemic racism is definitely linked and connected, intimately associated with health disparities. Okay. And we know that we cannot really address the health disparities and achieve health equity unless we deal with racism. That's the first thing. So there are a couple of things that APA has done and that they are doing. So um, right now we are in the process of really having the boards and committees to the various boards, which is the Board of Educational Affairs, Policy and Planning, Board of Professional Affairs, and Scientific Affairs and Public Interest, which coming out with a statement on racism, and there's going to be a resolution about that. And that will probably be come up into the February council meeting and hopefully to pass. And that would be really good because we know that things are tied into racism. And once APA develops that, adopts that policy on racism, then it just kind of allows us to continue to move forward with what we do. Now, at the same time that I have this presidential task force on achieving health equity, at the same time, APA has a committee on health equity that they're establishing at the same time. And in fact, we're going to be having a meeting tomorrow to seat the committee. And they, so they sent out the things. So this is a committee on health equity. And so we're going to have some of the members of our committee. There's going to be significant overlap, hopefully, of the committee members of what we're doing, of their committee and what we're doing. And so at the end of the year, we do not want this thing to die. So what we want to do is to pass this over at the end of the year to the committee on health equity, and they can continue to follow this. And so it won't just be recommendations that's going to go on deaf ears. Now, the other thing that you mentioned to me was about advocacy. If we don't have the advocacy about it, nothing is going to happen. So that's why it's going to be so important that we have our chief advocacy officer involved with this, Catherine McGuire, The other thing that I was very careful in doing was to try to select, we want to get a state executive, the executive director of a state psychological association on the task force, because we know that there's going to have to be some policy, there's going to have to be some advocacy, and we want to get some recommendations for that. So we're very selective and careful on who we're getting in that, so we can continue to advance this work and really look at advocacy. Now, I can tell you one thing for sure, that it's a lot of what happens will depend on what happens on November the 3rd of this year as to how we'll be able to advance this thing. So, we're trying to manage our expectations, but we understand some realities of the situation.
So true. And we were all in anticipation of what will happen over the next 3 weeks. We have another question.
What's gonna happen.
That is true. It can change on a dime, and we see that being played out already. Here's the next question, Jennifer. Can the task force provide ideas or recommendations? No, we've already answered that. Here's the next one. Can the task force focus on promoting trauma-informed settings, healthcare, schools, places of worship, work environments, as we know that trauma and adverse childhood experiences are associated with negative health outcomes, especially trauma-informed settings that serve disadvantaged populations?
Well, yeah, and I agree with that. So you do, and when you start thinking about health disparities and health equity or health inequities, we do have to look at, and not just, we look at trauma in that, traditional sense of trauma, but we're talking about, generations of traumatic experiences that's to be landed to where we are, and adverse childhood experiences, and how that impacts on where we are right now. So I would say that would be an area that we will be addressing as well. So the beauty of this, and so this is a good thing about having this discussion, is that it allows me to start opening up my mind to things that's like, I want to make sure that we include this, that we include that. And so, it's been kind of great to have this before we even get it kicked off, so we can have some things that we can look at. And so what's the role of trauma as it relates to health disparities or health inequities?
And that is a highly relevant topic. Because African Americans suffer from generational trauma.
Right.
Post-slavery stress syndrome,
right,
has been a term coined by Dr. DeGrew, and also Arkansas native psychiatrist Dr. Patricia Newton. And sadly, Dr. Newton made her transition. She's now with the elders as of last week. And we had hoped to bring her to Arkansas. She had been making presentations nationally and internationally on post stress disorder, generational trauma within the African American population. She has done extensive work, which we can still access, fortunately, but that is certainly a component that impacts health, and that's generational trauma. And thank you for that question. We have another question. Will there be a way for APA divisions and state associations to provide comment or ideas for the task force to consider?
That's a good question. Because I'm not, that is a good question. I don't know. That will be up to my task force, and I can bring that to them. When you do task force, we typically don't do that, but I can tell you this, that, the plan also is to have a resolution that we will have, and that will go to council. And then if that occurs, of course, they will be able to have comments, but at that time, most of the work will be done. but because that would be at the August council meeting. So let me make a note about that. But typically they do not, but that doesn't mean that it cannot happen. Okay.
As other questions are coming in, Jennifer, do you have any other areas that you want to highlight or discuss during this interval right now that you may not have?
Yeah, so one of the things that we want to do is have a formal APA policy on psychology and health equity. And so it would be, we want to have a policy that would be considered and approved by the APA Council of Representatives. So what we want to have would be like specific recommendations to promote innovative approaches for psychological science, education and training, psychological practice, public policy, and legislative advocacy. So we want to have all that. So we're talking about pretty comprehensive. And I like the idea of having input from the divisions and the SPTAs. So, and I'm going to bring that up to the task force because that's where all the knowledge is, the SPTAs and the divisions. And I know the rubber meets the road at the SPTA level. That's where things get implemented.
Exactly.
Mm-hmm.
Thank you for being receptive to that input.
Yeah, I like that actually.
Yes. You're getting some good ideas from Arkansas.
Well, that's why I want to talk. That's why I would like, my goal is always have a discussion as opposed to just having, some answers some questions, because clearly I'm not the expert. There are people in this field that have just done amazing work. When I have started doing all this, the research and putting everything together and doing all the readings, it's like there are people here that they have done deep dives into this thing. And so they live and breathe it. So it's been
right. Really exactly. Mm-hmm. And I would suggest looking at the work of Dr. Sherman James, who was one of our presenters last fall. He's retired now, but he's still available. Okay, we have a couple of other questions. And this comes from our president-elect of ARPA. We are initiating a task force related to extreme poverty and disparities in Arkansas. If you gave us some consultation, what would be the major points that you would have us to consider?
Oh gosh, now this is interesting. And I'm gonna say that, the expert on deep poverty is Rosie Phillips Davis now. So she's the one, she would give you the points on that as it relates to that. Gosh, it is so much as it relates to disparities and what I think that one of the things that you want to really look at would be the social determinants of health. So, remember we got that pie that's got these behaviors on this side that, that's 50%, but then you got the other 50% that's the environment, the stress and all of that impacts on that. And then you start thinking about, again, that, the medical model versus the socio-ecological approach, what happens within that person's environment, that 70% of it. So in addition to looking at things on the individual level, you have to look at it within the context of what's happening within their social environment. And we cannot avoid looking at what happens on day-to-day basis as well. So
here's our next question. For those that work with patients with chronic pain, what can we do to address health disparities and work towards health equity?
Yeah, that's one of the challenging things. So one of the things that I try to do, and because I do chronic pain work, so one of the things that I try to do is to help them to navigate the healthcare system. Now, many of the patients that I have that have chronic pain, they're usually Medicare recipients. And one of the things that I try to do most is to help them to have health literacy and to be able to interact with the physicians to the extent that I even have them to, like, these are the questions that you want to ask. And the other thing that I have is I have my patients I give, and I know it's still old school given that everybody's got these smartphones and stuff, but I have calendars that I give, and each day with each day, and then you can just write down notes for each day. And I give that to all my patients. I order them toward the end of the year and give them out to the patients. And I have them to write down questions that you want to ask the physicians. Because number one, they don't really know what to ask. Number two, they get anxious when they get in there with the doc who gives them all of 20 seconds and can seem to be annoyed when they ask for more time. So I have them to really try to be a driver that's responsible for their own health. Um, the other thing that I try to do is to help, and I go beyond just, doing cognitive behavioral therapy, but the other thing that I try to do is to try to help them in terms of making the good food choices given the limited financial resources, as well as the limitations in their physical functioning. So I try to work within what their strengths are and build upon that and helping them to manage not just with the pain, but in navigating the environment in which they're functioning.
Thank you, Jennifer. And on that note, there is a health literacy department at the University of Arkansas Medical Sciences campus who works with practitioners, and that can be a resource as well.
Mm-hmm. Mm-hmm.
So I would highly recommend that department, the health literacy department.
And the other thing about that is, and if they really, really have challenges, what you really want to do is to try to get the family members involved with it as well. So I think that will be important too.
We have time for one last question before you make your parting comments, Jennifer. And this is our last question. I think we are about 4 minutes away from the end of this session. And this is our last question. Maybe we can take one of them, depending upon how long this will take for you to answer. To what degree can APA use social media platforms to raise awareness about health equity? Is this being done?
Yeah, I can tell you what, it's not being done now, but that is the big plan. That is like the big audacious goal for us to have next year. Now, remember I talked about this summit that we're going to have, that we're going to be working with partner organizations, and that'll be in April. And so given the fact that I guess, I can't stay in Zoom anymore, but this is an opportunity for us to reach more and more people, through these kinds of platforms. And so that's going to be the big audacious goal, is to have that media campaign and, get the word out there about the health equity. So we want to put APA and psychology front and center in addressing health equity.
We will look forward to receiving those dates in April so that we can block them on our calendar. And I'm pretty sure that we're going to have to convene by Zoom because the end is nowhere in sight. With this
it's going to be Zoom. Well, but the good thing about Zoom is that it allows you to have access to audiences that you ordinarily would not have done. So I don't get to have to break bread with you in person, Pat, but I get to do this, and then I can do tomorrow. I can do another one tomorrow. It's so good like that. So that makes it a good situation.
And I think as a profession, we made the transition quite well to telehealth in the midst of the pandemic, with the support from APA and other professionals.
Well, I was saying APA has done just an amazing job in, getting the reimbursements. And not only that, I know a lot of the insurance companies have been covering 100%. And so they really have stepped up to the plate. And so I give them credit for that.
Yes. And that's the case here in Arkansas. And we're covered at 100%, no deductible, no copay until October the 23rd.
Yeah, it's been amazing.
We have just a couple of minutes left. I don't see another question in the Q&A box. This will give you some time, Jennifer, to have some concluding remarks before we sign off.
No, I just want to thank you so much for allowing me the opportunity to be here and to discuss this, what has been on my mind for quite a period of time. And I want to tell you that I appreciate the suggestions, the recommendations that you're giving, and we will certainly be looking forward to integrating them into what it is that we do.
And thank you again for accepting our invitation. We wish you well. We're looking forward to the official launch and the dates for the summit. Dr. Holmes, are you available to come in and give us information for our lunch break? Thank you, Jennifer.
Thank you.
Yes. Thank you so much. Thank you, Dr. Griffin. And I know that Dr. Kelly is signed off, but of course we thank her for her time and all of her information that she shared today. Thank you, Dr. Griffin, for moderating this Q&A discussion time. Much appreciated.